Clarity Clinical Solutions.
When you see a doctor, the goal is to treat you. When you join a clinical trial, the goal is to generate knowledge for future patients. These are fundamentally different activities, but many participants do not realize it. This confusion has a name: therapeutic misconception. The fundamental distinction between research and medical care. Research aims to generate generalizable knowledge for future patients. Medical care aims to treat the individual. Research follows a fixed protocol. Medical care uses clinical judgment. Research may assign treatment randomly. Care involves shared decision-making. Research may use placebo. Care never gives placebo. And costs are handled differently. The goal is the most fundamental difference. Clinical research aims to answer a scientific question: does this drug work? Is it safe? Is it better than standard care? The individual participant is a means to that knowledge. Routine medical care aims to diagnose and treat the individual patient. Every decision is made for the benefit of that specific person. In research, the participant may or may not benefit personally. In care, benefit to the individual is the only goal. Methods differ too. In a trial, every step is specified in the protocol: what assessments on what day, what dose, what tests. The protocol treats every patient the same to create comparable groups. In routine care, the doctor adapts to the patient. If a drug causes side effects, the doctor changes the dose or switches medications. The doctor uses clinical judgment, not a fixed script. Why participants get confused. The same doctors and nurses who provide routine care may conduct the research. Trials are held in the same hospitals and clinics. In both settings, a doctor prescribes medication, performs tests, and monitors progress. To an outside observer, the activities look identical. This is why the informed consent process must explicitly distinguish research from treatment. Therapeutic misconception: when a participant believes the trial is designed for their personal benefit. It occurs when a participant fails to understand that the primary purpose is to generate knowledge. Studies consistently find that 50 to 70% of trial participants exhibit therapeutic misconception. They believe the experimental treatment has been proven effective for them, even when the consent form clearly states the purpose is research. Why therapeutic misconception matters. If a participant does not understand they might get placebo, their consent is not truly informed. Participants who expect personal benefit are disappointed when the treatment does not help them, eroding trust. And participants who believe they are receiving proven treatment may be less likely to report side effects, biasing the results. Randomization is a key difference. In a trial, a computer randomly assigns you to treatment or control. Neither you nor your doctor chooses. This is the opposite of personalized medicine. In routine care, your doctor considers your specific condition and recommends the treatment they believe is best for you. Many participants believe the doctor would not let them be randomized to the wrong treatment, but the whole point is that nobody knows which is better. Placebo is impossible in routine care. In a placebo-controlled trial, some participants receive an inactive substance instead of the experimental drug. No doctor would prescribe a sugar pill to a patient with a serious illness; it would be unethical. But in research, placebo is ethical when there is no proven treatment. Participants who receive placebo are getting no active treatment for their condition. Extra tests and procedures. Trials often require blood draws at specific intervals, research biopsies, and quality-of-life questionnaires, even if you are feeling fine and your doctor would not order them. These carry risks and add burden. They are not for your medical benefit but for the research data. Costs differ. In a trial, the sponsor pays for the investigational drug and research tests. In routine care, treatment is billed to insurance. But the sponsor does not pay for routine medical care for other conditions. Medicare and many insurers do not cover routine care costs in trials, though this is changing. Sometimes research and care overlap. Pragmatic trials compare standard treatments that doctors already use, the only difference is randomization. Comparative effectiveness trials ask which existing treatment works better. Even when the treatments are the same as routine care, being in a trial adds extra oversight, extra data collection, and the uncertainty of randomization. Questions to ask. Ask your doctor, if I were not in this trial, what treatment would you give me? Is the goal to test a new treatment or compare existing ones? Can my doctor change the treatment if it is not working? Ask yourself, am I okay with not knowing which treatment I am getting? Am I okay with the possibility of placebo? A clear consent form is not enough. If anything is unclear, ask again. So here is what we learned. Research aims to generate knowledge for future patients. Medical care aims to treat you. In research, the doctor follows a protocol. In care, the doctor personalizes treatment. Therapeutic misconception, believing research is designed for your benefit, affects 50 to 70% of participants. Randomization, placebo, and extra tests are hallmarks of research that never occur in routine care. Always ask, how is this different from the care I would get if I were not in the trial?